Hello, my name is Sarah, and I am the volunteer for the MAVEN Project. Thank you all for joining us today and our friends at the Mariposa Community Health Center for hosting today's session, ADHD in Adolescents, a Practical Guide to Management. Our speaker today is Dr. Najah Musacchio, and I'm just going to run through her quick introduction here. Najah Musacchio, MD, is a board-certified pediatrician with expertise in adolescent and young adult health, patients aged 10 to 25. She has extensive experience in academic and community-based settings providing mental health care. She was an attending physician in the Parasnack Family Division of Adolescent and Young Adult Medicine at Lurie Children's Hospital of Chicago, and assistant professor of pediatrics at Northwestern University Feinberg School of Medicine. There, she started and directed the mental health and primary care program, providing consultative care for mild to moderate anxiety, depression, and ADHD, and educating residents on how to incorporate mental health care into their future practices. As a staff physician at Girls to Women Health and Wellness, Dr. Musacchio provided primary care and collaborative mental health care, including eating disorder treatment for girls and young women. She was also formerly the lead clinician at Uptown Teen Clinic in Chicago. Dr. Musacchio has spoken on many adolescent health topics, as well as mental health care to community groups, trainees, and clinicians. All right, and with that, take it away.
Good morning, everybody. I'm going to share my screen here. All right, can everybody see that okay? Thank you so much for having me. I'm really excited to talk about ADHD in adolescents. It's a clinical interest of mine. And also I have a lot of personal experience speaking as someone with ADHD, and I have 3 teenagers, all with ADHD. So it's super fun. But also if I make any jokes, please understand that it's coming from a place of love, if not extreme frustration. And if you have any questions along the way, please ask them, and I'm going to answer them as I go. Here are some housekeeping slides. So learning objectives for today are to describe the presentation of ADHD in adolescents, strategize starting ADHD medications, and address common side effects and challenges. So ADHD involves these 3 core symptoms of inattention and/or hyperactivity and impulsivity. And normally we think about this as just affecting, somebody's performance in school. But if ADHD is not addressed and managed properly, it can have this huge snowball effect on a young person's life, and sometimes even with permanent repercussions. ADHD can make it less likely that you complete high school, that you go on to college, that you can hold down a job, that you can have healthy relationships with others. People with unmanaged ADHD are more likely to engage in risky behaviors like fast driving, substance use. They are more likely to have depression and anxiety. They're more likely to injure themselves through accidents, and they have a higher early death rate. They're at higher risk for suicide when they have depression compared to those who only have depression. So for all of those reasons, the American Academy of Pediatrics recommends that we evaluate patients aged 4 to 18 who have school or behavioral problems, and then any of those core symptoms for ADHD. These are the DSM-5 criteria for ADHD. So for inattentive presentation of ADHD, a patient needs to have 6 out of 9 inattentive symptoms. And then for the hyperactive impulsive presentation, you need 6 out of 9 symptoms. And then for the combined presentation, you need 6 out of 9 inattentive, and you need 6 hyperactive impulsive. So not like 3 plus 4, something like that. You need to meet criteria for both. And those symptoms need to have been present for at least 6 months. Those aged 17 and up only need 5 out of 9 of those symptoms. Several symptoms need to be just present before age 12. So not even interfering in function, but just noticed. And they need to be present currently in at least 2 settings. So that would be like school and home. Symptoms need to interfere with school, work, or social function, and they need to not be explained better by another condition. So here are the 9 inattentive symptoms. And what you'll notice here is that they all start with often. So this is really key because I know a lot of times people are like, oh, like, doesn't everybody have a little bit of ADHD? And it's not true. No, actually, we don't. Because people with ADHD often have these symptoms and they're to the point of interfering with their function. It's also up to us as clinicians to judge about the appropriateness of these symptoms given the patient's developmental stage. Because these symptoms are described exactly the same whether a patient is 4 or 94. So running through these symptoms often fails to give close attention to details or make careless mistakes. Patients might say they make like stupid mistakes, sloppy errors, like, oh, I forgot the entire back page of a test, or I didn't see that they wanted me to subtract, instead I added. You might even see this in your intake paperwork in your clinic, where they're not putting their name on something, they're not answering all the questions on the Vanderbilt. Like, note that, that's almost, it's like an objective finding. Often has difficulty sustaining attention in tasks or play, like especially prolonged attention, like listening to my talk today. Often does not seem to listen when spoken to directly. Kids with inattentive ADHD are described as like spacey, space cadet. She's out of it all the time. She's always in her head. Sometimes you might be talking to them and it's like the lights are on, but nobody's home. Like for my kids, where I'm like, I think they're like staring like right through me. Often does not follow through on instructions and fails to finish tasks. So especially like a multi-step task, kids might be okay and like hold it together in the beginning, but then they kind of fall apart. They do their homework, but then they forgot to turn it in. Often has difficulty organizing tasks. So kids with ADHD will have like next level messy rooms under their bed, the locker at school that you open up and like everything crashes down on you, the backpacks where it's crumpled papers at the bottom, lunch from like 2 weeks ago. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. Procrastination, I think, is a hallmark feature of ADHD in adolescents. It's putting stuff off that you feel like is going to just take a little bit of concentration or a lot of concentration. Often loses things, important things, phones, homework, keys. Often easily distracted by extraneous stimuli or even stimuli in your own head by your own thoughts. Often forgetful in daily activities. They might not skip appointments with you or come super late or not return texts or messages, or I forgot to pick up the medication. I forgot we needed to follow up, things like that. Here are the hyperactive impulsive symptoms. So kids with this presentation of ADHD are hyperkinetic. They're kind of like always in motion. You might see them in your exam room, often fidgeting, tapping, squirming. And I would write that also in your note. So they might be, playing around with a piece of paper, twirling a pencil, twirling hair. Often leaves seat when needs to be seated and often runs around when inappropriate. So, okay, you're probably not going to have a 16-year-old who's like running around in your exam room, right? But this is manifested as a profound feeling of restlessness. Like, I cannot sit here anymore. Unable to play quietly. Kids with ADHD tend to be loud. There's like no volume control. Often on the go or driven by a motor. So my husband would say about my son, my youngest, that, does he have a battery that we can remove? Because it's really like all day from time you wake up until the time you go to bed, go, 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 go. Often talks excessively, like we call it yapping in my house, just a lot of talking, giving your TED Talks, if you will, to audience of one. Kind of like going off on tangents, and it can be annoying to peer groups, especially as somebody gets older. Blurting out an answer before the question is finished, so that can get somebody in trouble at school, and also offend people. Difficulty waiting their turn, and then often interrupts or intrudes. There are some soft signs of ADHD that when I hear them, in addition to those core symptoms, I'm like, this kind of gives me an ADHD vibe. One is time blindness. always running late to something, always to the appointments with you, doing things at the last minute. I call that ADHD standard time, where you're always like 10 or 15 minutes behind, like leaving at the time that you should have already been there. Emotional hyperarousal. This might eventually get added to the DSM-5 because it's such a common manifestation of ADHD, but it's almost this like impulsivity translated into emotions, where kids with ADHD can have big responses to things like big frustration or anger or a temper tantrum or crying when it's really shouldn't, when the situation doesn't really warrant such a big reaction. Sleep problems are very common, often because somebody's procrastinating and doing their homework late at night. And then hyperfocus. That's gotten a lot of attention recently on social media about being an ADHD superpower. And it's kind of related to procrastination. Like when you're really under the gun, then you can really focus on something and be extremely efficient. So when people with ADHD are motivated, or by usually externally, or if they are interested in something, they absolutely can focus. And so in this way, ADHD is not really an issue of inattention as much as it is attentional dysregulation. So you might have a parent who says, well, my son plays video games for 6 hours or it's like 10 hours straight. He doesn't even get up to eat. Like he can pay attention to that because he's interested in it. And to his detriment many times, because kids with ADHD aren't putting the attention maybe where it needs to be. So there are certain patients that might present later. Those who are maybe bright or have a high aptitude are girls. They can kind of slip under the radar for longer because they can maybe get away with not really listening in class or not really finishing their homework. But then it tends to catch up with them at times of increased executive function demands, like entry to middle school, where now you have a locker and multiple teachers, or entry to high school, when you have all of a sudden quadruple the homework, or even entry to college. Also, people who have inattentive ADHD, they can slip under the radar for longer because it's not disruptive to the classroom. Like you're not yelling something out that catches a teacher's attention and then you get a phone call home. Someone with inattentive symptoms in a big classroom, I mean, you can be looking right at your teacher and not even processing anything going on, and everything will seem okay. Family history is really important because ADHD seems to have a very high genetic component to it. So if someone is coming in for an evaluation and they're like, oh, my sibling has ADHD, then that's already kind of it's like a soft sign, like, okay, this is probably going to be ADHD. It's really important that we screen for comorbid conditions, because these conditions not only commonly co-occur with ADHD, but they also mimic ADHD. And so we want to make sure that we're not mistaking something for ADHD, and missing something else. So this would be emotional and behavioral conditions like anxiety and depression, oppositional defiant disorder, conduct disorder, and substance use. Also, there's developmental conditions, dyslexia, learning differences, autism. And we also just want to screen for any concerns about sleep and cardiac conditions that might make stimulants contraindicated. So for diagnosis, I use the Vanderbilt. Not sure what you all use, but Vanderbilt is very, very commonly used. It's free and it's online. So that works for me. And there's forms for the parents and for the teacher. And then there's initial and follow-up forms. So what I would do is at that initial appointment for mental health is I would give the initial parent form to the parent and to the student, to the patient. And so that part is off-label, but it's really commonly done, especially as kids are getting older, because you want to see their perspective of their symptoms. There's stuff that they notice that their parent is not noticing. And at that initial appointment too, you want to give the multiple teacher forms. Hopefully you can get like 2 or 3 of them back from a teacher or even a coach that you can look at later. And there's a question in the chat. Oh, okay. So somebody said in the chat, one of our therapists recommends a scared as well. I completely agree with you. And I'm going to get to that. And then at follow-up appointments, I like to give a parent follow-up form to the parent and the kid at every single visit too. At that initial mental health appointment, I think it's really important to do really broad, holistic view of what's going on. So just as one of the clinicians just mentioned, I like to screen for depression. I give the PHQ-9 and I give the scared for anxiety. It screens for a number of different anxiety disorders in kids. And there's a form for the kid and there's a form for the parent. I think it's a good idea to do it at first. Like sometimes I think as, you know, in a busy practice, when you're hearing kind of symptoms about ADHD, you're like, they kind of get pigeonholed early into just ADHD. And then we might miss out on these other diagnoses. And then like down the road, they're not responding to the stimulant. And you're like, wait, did I like miss something? So it's better to get it all out there in the beginning. So this is the ADHD Vanderbilt initial form for parents. So when I'm sure you all have seen this before, but symptoms that are 2 or 3 often or very often are positive. So when I get this back, I put a line down the middle. So I know everything to the right is positive. And then these number 1 through 9, put a line under it. So I know I'm looking for like 6 out of 9 of these or 6 out of 9 of the hyperactive impulsive. And then all of these other stuff at the bottom, this is screening for other conditions. And then you have this performance section that is about school and about relationships. And a question that comes up is, okay, so let's say they meet criteria for ADHD, everything else, and then they're like, school performance is above average, like they're getting Bs, B pluses. Could they still have ADHD? And then there's another question here in the chat. Okay, so in the chat, it says several of the behavioral health staff are joining from a room together. At the end, could you go into more, why we give the screenings repeatedly? Yes, for sure. And I'm actually going to talk about that right now too. And then another question is, how many minutes do you schedule for the initial evaluation and follow-up visits? Oh, good. That's such a good question. This takes time. And so I think, and that is the biggest challenge with providing mental health services in a primary care setting. As much as you're able to have, I would try to get it. I would try to have the patients arrive early to the appointment if they can and fill out the forms in advance so that you can look at it even before you go in the room and score it. And then ideally, I'd want to have 45 minutes if I could, if we're talking about a really broad mental health initial appointment. 40 minutes, something like that, I think would be helpful. Follow-up appointments, depending on what's going on. I mean, I would ideally want at least 20 minutes. Okay. Oh, so anyway, going back to if someone's school performance is above average, could they have ADHD? And yes, I think that they can have ADHD. If their potential is higher and they're not meeting that potential, then their symptoms are impeding their performance. And some kids, even if they're getting Bs, B pluses, they're like spinning their wheels doing homework for hours. That should not be taking them that long. All right. And then this is the follow-up form. So I like to give this follow-up form at every appointment. I know it takes time, but for me, I think it really speeds up the appointment because you can kind of see what you want to focus on with the family, what's important to them. So the follow-up forms only focus on ADHD core symptoms. And you can track this over time as well, if you want. You know, you could say like, I'm going to track the number of positive symptoms, or I'll track the total symptom score by adding up all the 1s and 2s and 3s out of the symptoms, and then see if how that number goes down over time and share that with the family. And then let me see, there's another question. Oh, any nutritional deficiencies, abnormalities associated with impaired attention or hyperactivity? That's such a good question. You know, typically I think that it's going to be pretty low yield. I mean, in a review of systems, maybe you'd want to be screening for any other, potentially signs of anemia, I guess, is something that would come to mind. If somebody's anemic and has low energy, lead maybe in a really small child, but we're talking about adolescents here. Those are the main ones I think that would come to mind. But I'll think on that. Okay, so then the other reason I like this follow-up form is it has side effects that they can check. And then there's an area for comments too. So you can get an idea about what the family wants to talk to you about. Okay, so moving on to treatment. Medication is first-line treatment for school-age kids with ADHD. So there's no role really if we diagnose somebody with ADHD to say, let's see how it goes with school supports or with therapy. They need the medication to help them get more out of that therapy or school supports. So we're kind of doing them an injustice if we say we want to wait and treat them. And this is according to the American Academy of Pediatrics. So if someone is ages 6 to 12, then we also want to add parent training and behavioral management. And that can be delivered through a counselor in your clinic if you have one. There's free online resources I have at the end of this talk on the last slide that you could refer patients to. And you can also talk to patients about this yourself. This is kind of like skills in parenting ADHD kids. And it revolves around setting clear limits, setting clear rules of your house. Like, what are the rules of your house? Setting expectations for consequences, following through with those consequences if their behavior is not what we want, and providing structure, recognizing the good that kids do, trying to ignore the little like bad things that they do, and responding to kids with being in a calm way. That's the hardest part. And especially because a lot of kids with ADHD have parents who have ADHD and parents maybe who are not diagnosed. So those parents may be even more likely to be responding in a like really frustrated way. And it can be very frustrating, believe me. So, we want to talk to families about how to avoid screaming, yelling, physical aggression, because it can make things a lot worse. And then also school supports. So if I diagnose somebody with ADHD, I'll just have like a form letter that I can just punch in stuff and saying this person was diagnosed with using the Vanderbilt, blah, blah, blah. And this may be helpful. These accommodations may be helpful in school. So I just say that because I'm not looking at them in school. I'm not psychoeducational, specialist. I'm going off what they're telling me. So I can give generic ideas like 1.5 times on tests and preferential seating so they can sit in the front of the classroom, and access to a fidget or gum or something. For patients ages 12 and up, then you could consider adding behavioral therapy and also those school supports. Also talking to the families about requesting a 504 plan from their school. Of the medications, stimulants are first line. They work the best. Like, this is our default, is a stimulant. I think there's a lot of fear around stimulants that's unwarranted. About 80 to 90% of people respond to one of these stimulants, and they can really be life-changing for somebody. And our goal with treatment is not that to have zero side effects, but it's to make the benefits worth any side effects. I think sometimes like an error that's made in a primary care setting is that we undertreat with stimulants. Like, we kind of put them on something and we're scared to go up on it. But if it goes up too high, as long as you're going up slowly, you don't risk much, and you can just go back down the next day. I added on here exercise because exercise can also play a role. And I think it's something that gets forgotten about, especially if we're talking about kids like school-age kids, younger kids. If going and playing on the playground, if it's feasible before school, or if it's feasible biking, walking to school, helps get out a lot of that kinetic energy. So they're ready to like sit down for hours, which is not ideal. And also playing after school, playing on that playground, doing something physical is a good way to burn off kind of like pent up energy and frustration from a school day. And then exercise alone, like we don't need to recommend to kids like, oh, run on a treadmill, like when they hate it. Like you want them to do something that's in some way fun for them and sustainable. Okay, wait, there's some other question. Oh, somebody said, you mentioned a parent avoiding physical aggression. Is there a higher risk of child abuse in patients with ADHD and or having a parent with ADHD untreated? That's such a good question. I don't know, honestly, if there's like data on that. I mean, if people with ADHD do tend to be more, you can have some emotional volatility, and some trouble managing frustration. So I can just see how that might be a potential for conflict there. Sometimes the best thing that you can do to treat your patient's ADHD is to recognize the parent's ADHD and that they get into treatment for it. You know, even like a question like, you know, ADHD is so highly inherited. Have you ever wondered like if you had it or if someone else or a dad or something had it? And a lot of times you'll hear that they have. All right, so then in terms of stimulants, there's like 50 billion stimulants out there, and it can be very overwhelming. So, you know, thinking about it, there's the amphetamine group and the methylphenidate group. And really, both of those groups work awesome, and they have the same side effects. So picking one or the other, generally speaking, is going to be good. The only thing that maybe would push you in one way or the other is family experience. If you know sibling is on Adderall XR, do Adderall XR. You already know their insurance covers it, and there's some, who knows, idiopathic response or something, but I would go with that. Okay, I'm looking at this chat again. Okay, somebody said, sorry if we're jumping ahead. Can you address the concern about addiction with stimulants? I will definitely later in this. For ages 6 to 12, it mentions, yes, PTBM, but also BT for kids, right? Just confirming. Oh, behavioral therapy. Oh yeah, I just lumped all that together. Actually, what has the most data behind it is the parent-driven training, as opposed to like individual therapy for those kids, because it really is so much of the behavior is kind of driven or structured by the parent in those younger age groups. And then there's another question. In adults, there's a concern for misuse of controlled substances. Yeah, okay. So I'm going to talk about that later, but I know that that's a big concern. Okay, and then in terms of duration of action, so, you know, there's short acting, those last for a few hours. There's in the intermediate acting ones, those are like 6-8 hours. And then there's long acting, which is usually 8, 10, even 14 hours. For adolescents, our default is long acting. That is where we should be going, because that way they can take it in the morning, it can last the whole school day, and then ideally it also goes into the early evening for homework or other activities. There's not really a role for short acting, to start with a short acting, I should say, for an adolescent, because then you're doing bumps like this instead of smooth and all day coverage. And of course, there's the more abuse potential with the short acting. So what you want to do is first get them geared up on this long acting, figure out what the right dose is, how long it's lasting, and then see, might they also need a short acting from the same group to use at like 4 o'clock or right after school to cover them at homework time in the evenings or activities. And sometimes kids want to use a short acting on weekends, because if you sleep into like 11 or noon, you're not going to want to take a long acting that's going to cover you until like 11 p.m. Also consider formulation, find out if kids can swallow pills. Some of these are available where you can, you know, put them on applesauce or patch. Availability, don't get me started on this, because it's like a cat and mouse game trying to figure out, what can I put somebody on? Where can you pick it up? And then, oh, the pharmacy's out of it. This is like a nightmare. So where you are, I'm not sure what state you're in, but things are going to be different regionally, and then they can shift like day to day. So I'm sorry, it's very frustrating, that situation. But when we start with this long acting, we want to start it low and then titrate it usually over like a week period. I put 3 days. I mean, this is like if you have an older adolescent who's maybe already been on a stimulant and you're just kind of switching around stimulants and the family is savvy, that you could do it in over a shorter amount of time. Maybe give them like 3 days on that starter dose. The reason is because we're not waiting for this to like build up levels or anything like that. Like, it is what it is. The reason we give it more time is to allow people to get used to the side effects. So, and depending on your clinic is set up, if you're having if people have ease of access to come in and see you in person, or if you're doing phone visits, or if you're doing messaging, like, it all depends on so many factors, how you want to structure this. But typically, like, you'd want to see them back in person, I think, around 2 weeks. Like, you don't want somebody to go and start on like a low dose and then be like, I'll see you in a month. Like, that is terrible, because people are going to be potentially languishing on these suboptimal doses, or on a dose that they don't even feel, for way too long. So we kind of like want to go at this a little bit aggressively and tell the families that these medicines, like, when you take it, it's going to start to kick in over a few hours, or I'm sorry, not a few hours, over an hour or two, reach a peak around lunch, and then it's going to fade away. And by the end of the day, it's gone. So if you hate it, never take it again. Any side effects you have, you'll notice in the beginning, like those first few days. And side effects tend to get better with time. So if you can kind of like hang in there a little bit and supportive care, usually it's not enough to make you want to stop. Okay, I'm looking at the chat. Oh, these are all.
Sorry, Dr. M, it's me. We're just trying to figure out what's going on with the attendance. So I am.
Oh, yeah.
Sorry.
Okay. Oh, no. There is a question in here about, what are your thoughts on parents wanting a summer or weekend break from medication? I would want to understand why they want a break. Sometimes, like, if somebody is having a lot of side effects from the medicine, it might make sense for them to not take it on weekends if the symptoms are not interfering that much, with their lives. But typically, for patients who are adolescents, like, this ADHD symptoms are affecting their social relationships, relationship with mom, getting stuff done around the house. So they might actually benefit from being on a stimulant over a weekend. Okay, I'm gonna look at this Q&A too. Okay, somebody asked, once stable, do you require monthly follow-up for refills, or do you give 3 months? Yeah. Okay, so what I would tell the family is, like, when we start off, like, we want to get you on the right dose, like, as soon as we can. So there's going to be a lot of there'll be frequent follow-up, whether it's by phone or you're going to be coming into the office a bunch. But once we get you on the right dose, then we can space out those visits. I don't know about the laws in your state, but in Illinois, you can give out up to 3 months at a time in advance of like post-dated prescriptions for stimulants. So the longest to go would be like 3 months, I think, is pretty reasonable for an adolescent. Maybe, I don't know, you could go a little longer, but you still want to have a phone check-in at least, or some kind of an online check-in at 3 months. But for a teenager with ADHD, I just think it's pretty good practice for them to be seen in person every 3 months. What we don't want to do is set up unnecessary barriers, like having somebody come in to pick up a prescription every month or see you every month when it's not really clinically warranted, is not appropriate either. So here are the side effects for all the stimulants. Common decreased appetite, sleep problems, headaches, stomach aches, and behavior rebound is when somebody has this rebound, crabbiness, crying, anger, temper tantrums, when the long-acting stimulant is fading away, like late afternoon. Infrequent side effects are weight loss. So usually for adolescents, like, once they're on a good dose, they might lose a little, like I don't know, few pounds, but then they usually come back up once their body gets used to it, to their baseline. But we do need to be monitoring weight, heart rate, and blood pressure and height at every visit. Increases in heart rate and blood pressure are usually really small, and not clinically significant. Growth suppression can occur if someone, especially if somebody is on a stimulant daily from a young age. But if talking through families about this, like we will be measuring the child like at every visit following this. If we need to make any changes, we will. If someone does encounter growth suppression, it can be a few centimeters off of their adult height. And so that's kind of like a potential long range risk that we would monitor for versus the risk of not treating is like right in front of us, right? If we don't treat ADHD, what happens? They might fail school or have a lot of trouble with their friends. Anxiety can worsen sometimes on a stimulant, especially if somebody is sensitive to kind of these like physical symptoms of your heart rate going up a little bit and your mouth being dry. But one thing to be careful of is that sometimes people say like, oh, well, this patient has anxiety, so I didn't want to put him on a stimulant. But generally speaking, I don't think that's the right thing to do. The stimulants work best for ADHD, and ADHD that's unmanaged causes so much stress and anxiety that bears more anxiety. It's like this horrible snowball that you can get. So usually if somebody, like if you do the scared at the first appointment and there's some like mild anxiety going on there, that usually improves once you treat the ADHD. Okay. I'm just looking at this chat again, but it looks like it's just everybody's names.
Yes, it's for me, I promise. If I see a question, I'll interrupt you.
Okay, yeah, and then this other question about how do you screen for cardiovascular disease prior to prescribing? Just by history exam, or do you also get an EKG? So just by history and exam is good enough. We don't need to get an EKG before prescribing a stimulant. Okay, so memorize this screen. Oh my God, my dad jokes are so bad. This screen is so busy, I know, but I wanted to show you this resource is so awesome. If you haven't heard of it, it's www.adhdmedicationguide.com. It's free and you can print these off and it's updated regularly. So this is a picture of all the different methylphenidate drugs, and it will give you what it's available in, like, can you put it on applesauce? Do you have to swallow it whole? It gives you the starting dose, the dose range, and how it's all dispensed, and if it's generic or not. The pictures of the pills are also really helpful in case somebody says like, I was on the yellow pill, then you can look it up and show patients actual size. So this is one page of it, and then they also have the amphetamine and the non-stimulants. So it's a good one to print out and have in your office. There are so many methylphenidate medications. I think it's a good idea to be comfortable with one of them and then kind of have that be your go-to, especially if you know what is available and what is covered by Medicaid, if that is your clinic population. Like looking up Medicaid preferred drugs 2024 in your state and seeing what is preferred. So for example, in our state, Concerta, methylphenidate extended release is a go-to. And here you can see the duration and the starting dose. You would pair that with short-acting methylphenidate Ritalin. So you wouldn't do like Concerta and Adderall, for example. You want to stick to the same class. And then for the amphetamines, I wanted to highlight lisdexamfetamine, Vyvanse, because everything else being the same, that would be my go-to as the first medication for a teenager. The reason is because it's a prodrug, and so it is even harder to abuse. It has to be activated by eating it. And it's available in chewables and capsules. The other thing that I like about it is, and I'm not paid by them, the other thing I like about it is that I would give like 40 milligram capsules as an initial prescription. And then I would have, as long as the family felt comfortable with this and didn't need more support, but say like, take 4 ounces of water and then dissolve a 40-ounce capsule in the water, stir it up, and then immediately drink half of it. So that would be around 20 milligrams. So then do that for a few days or a week. And then if you feel like, the side effects aren't too bad, but I still need some more coverage, then you can go up to drinking 3 ounces out of that mix every day and then see how the 30 milligrams goes. I liked doing that because it was like, gets very complicated when you're trying to dispense multiple different doses and like, now we're going to go up to this and this didn't work. This gives you a little bit more flexibility with that. The problem is like, at least here, there's a shortage. You cannot get generic Vyvanse here anymore, just the brand name, which is really expensive. The other option is mixed amphetamine salts or Adderall XR, just doesn't last quite as long. And that's the other reason too, that lisdexamfetamine is so nice for an adolescent, is because it lasts so long, then it really gets into the homework time that you know that they've got in high school. And then that's paired with Adderall. So when starting medication, we would first do amphetamine or methylphenidate group. And then if we're kind of hit a ceiling with it, like too many side effects, not enough help, then we go to the other class. And if we hit the same problem with that, first we want to make sure we actually have the right diagnosis. Like, is it not ADHD? Is it something else? Or is there something else on top of the ADHD? Does the patient potentially need neuropsych testing or educational testing, psychiatry eval? If we're confident about the diagnosis, then you could either switch to a non-stimulant, so monotherapy, or consider adjunct treatment with a non-stimulant. Atomoxetine, probably the most commonly used non-stimulant, is if someone has a contraindication to a stimulant, or they just can't tolerate stimulants like at all, they're too sensitive to them. Atomoxetine was originally like made as an antidepressant. So you have to take it every single day, and then it takes weeks to build up in your system. But once it builds up, then you are supposed to have like all day, all night coverage. But the problem is the coverage just ain't that good. Like the efficacy is not as high. But something that is also an option is that if you have somebody who's on a stimulant and the stimulant was helping, but it's like, oh, causing so many side effects, you could start atomoxetine at the same time, and then you might be able to use less stimulant, okay? Or like a lower dose, or maybe they only need to use a stimulant now, like on a test day or in school, something like that. And there's a black box warning about suicidality just because it's in that class of drugs. Another non-stimulant is guanfacine ER. That's used more than adjunct treatment in adolescents. And it's also taken every single day, and it's just weight-based. So guanfacine is helpful if you have somebody on a stimulant, maybe you've tried more than one stimulant, and you've gotten up as high as you can, too many side effects, but you still have some persistent hyperactivity, let's say, emotional reactivity, or they're having trouble with sleep. You could consider adding guanfacine on in the morning, but it's not going to help with attention. So I want to just mention all the awesome things about ADHD too. I try to make a point of this when I'm diagnosing somebody with ADHD, because like the whole time we're talking about like, this is bad, she has this problem. But trying to talk to the families about how ADHD is really cool in a lot of ways. Like some of the most creative, intelligent people on the planet have had ADHD, and that there's an evolutionary reason for it. Back in the caveman days, everybody else would have been like focusing on putting their seeds in the ground, and you would have been looking around and you would have noticed the tiger running at all of your family and saved everybody. So we want this type of thinking in our society. And when we treat somebody for ADHD, it's not because we're trying to fix somebody, it's because we're trying to help them reach their potential, kind of like somebody wearing glasses who has trouble seeing. Our humans were not meant to sit in a desk all day long. And so we're trying to help support them in this environment. Okay, so then I have a bunch of clinical challenges, and some of them do go over some of the questions that were brought up. So I think maybe I'll just go into these and we'll see how many we can get through. Okay, oops. So this is a 12-year-old girl who presents with anxiety and depressed mood. She has a poor self-image and has been hanging out less with friends. She's always worried about school. On Sunday nights, she's irritable and has trouble falling asleep. Her grades have gone down. She was seeing a counselor, but it did not help her mood or stress level. Do you all have any thoughts about this? Like, what do you think could be going on?
You can put your answers in the chat now. I'm done messaging everyone.
Thanks, Kristen.
Bullying.
Bullying, okay, yeah, you want to ask about what's going on with their peer group, because it sounds like the anxiety is centered around Monday, around school starting. Another thing to consider, oh wait, somebody else is saying something.
We
Oh,
have
depression, yeah. Okay, that's great. You guys have a lot of good ideas. Depression and low self-esteem due to ADHD, right? So kind of thinking like outside the box, because on face value, this kind of sounds like depression or anxiety, right? If you have patients who have depression or anxiety, and then maybe they've already been in treatment, like seen a therapist, even been on an SSRI, and they're not getting better, definitely think about ADHD, because it's something that might have been missed in the beginning, in the initial evaluation. Like sometimes patients get pigeonholed, but we want to keep a really broad lens kind of on mental health. And then wrong fit therapist. Okay, I didn't weird type that wrong fit therapist. No, that's true though. I mean, maybe it's not a good fit and that the patient does have anxiety and just is not seeing somebody that she's like meshing with. Okay, this is a really silly meme, but really think about it. We could be misdiagnosing depression or anxiety. Yeah, life stressor. We definitely need more history on this patient. So there's a lot of overlap between ADHD and anxiety and depression. And this is such a common question that comes up in primary care is like, what is what? Like, how can I tell the difference? It's very tricky because ADHD that's not managed causes so much anxiety and stress. And ADHD that's not managed also causes you to feel really sad and hopeless. But those type of secondary symptoms should improve with ADHD treatment. And then people with ADHD are also more likely to have a second diagnosis of anxiety or depression. So the way to kind of figure things out is through history. If someone is saying that they're not paying attention in school, we want to know, like, what is the story? What's going on? What are you thinking about instead of paying attention? Is the mind just wandering, going to like all different types of things? Because that kind of sounds more like ADHD. Or is it, are you perseverating on something that's kind of irrational, like an anxiety about something? That sounds more like an anxiety disorder. Ask if their patient is talking about having worries. Think about if the worry is rational. Like, does it actually make sense? Someone with ADHD constantly worries. Oh, did I forget my homework? Oh, did I pack my bag? Oh, do I have my lunch? Oh, when I leave the house, I have to make sure I have my, okay, let me say it out loud, my purse, my phone. The reason for that is because I have forgotten my purse, my phone. So it's a rational thing to have to go, almost sounds like OCD-ish, to have to be like, okay, did I do everything that I need to? Versus somebody who has an anxiety disorder, their worry is more irrational. It doesn't match the necessity. It's like, it doesn't match the level of risk. It doesn't make sense. If someone is like thinking all day about, I'm worried something's going to happen to my mom. I'm worried my mom's going to get in a car crash. I'm worried my mom's going to have a heart attack. That's something that is unmatched in actual risk level. People with ADHD also can have this emotional hyperarousal, but it tends to be kind of like, I would say like kind of like makes sense. Like it makes sense for, let's say, a kid to be really mad. These kids are not playing by the rules in this basketball game. I'm gonna start yelling at them. But then, 1 minute later, like I'm calm and I'm having fun again. That's kind of more of an ADHD thing versus I'm sorry. So to clarify, it makes sense that you would be frustrated at that, right? But it's too much of the frustration versus a mood disturbance. When someone is depressed, they have a persistent low mood that is like irrational, that doesn't make sense for what's going on around them. And it goes on and on and on and on. Whereas someone with ADHD, you're going to see them being happy and enjoying something. Also, sleep disturbance, trying to get at the root of, why aren't you sleeping well? Are you perseverating? Are you worrying, thinking about stuff? Or are you playing video games and then doing your homework at 11 o'clock at night? So trying to get more history from the patient about the chain of events, what is causing what is like the root cause what symptoms are causing the most impairment, and asking that like straight up, like what is the most bothersome issue for you? What is taking the biggest toll on you? If everything else is the same, you're like, okay, I think they do have ADHD and they have an anxiety disorder. Like, what should I do? I don't know what to begin with. I would be biased towards starting ADHD treatment first, because with ADHD treatment, you're going to know really fast if it's going to help you or not. And versus if we are talking about starting in counseling and starting in SSRI, especially, that can take months, whereas a stimulant will be more quick. And if we do think the anxiety, a component of the anxiety even is related to the ADHD, then what we would expect is that those scared numbers are going to come down. So I know there was a comment on that before about doing these like at the initial appointment. That's why this is so important that we do a PHQ-9 and a scared and the Vanderbilt at that initial mental health appointment, so we can see what's going on. And then for somebody who has some like, their total scared maybe is mildly elevated, it's like 25 or something, or 30, then we could say to them, like, let's see what happens like next time I see you, and I would expect that this number is going to come down.
Dr. Musacchio, there's a couple of questions in the chat that I don't want to get missed. If anybody going forward can just put their questions in the Q&A box, because the chat is full of lots of things, that would be great. But do you see the questions, or would you like me to read them to you?
Yes, no, I'm looking at them right now. Okay, somebody said, or a history of trauma. Yeah, that's really good. Like I kind of like breezed through that history. You are all putting out great ideas for a differential diagnosis and how you would get about that at the history. Okay, and then somebody wrote, do you have a link visual aid that shows the American Academy of Pediatrics recommendation of medication versus behavioral intervention? I don't, but I can send one to you. I'll get a screenshot and send it. I'll make a note to myself. You mentioned Vyvanse as your recommendation for teens. What is your recommendation for younger kiddos? I would just, first of all, I would let the family history guide me. And for the youngest kids, like I would go more the methylphenidate group, just because it's been around longer. And maybe, I don't think this has even been borne out, but there are some theories that maybe like the methylphenidate might be better for more of the hyperactive symptoms, hyperactive impulsive, and that tends to be more present when kids are younger. And then as kids age, like the impulsive symptoms are the ones that tend to persist. So, that's why maybe Vyvanse in the teenagers. So Concerta, you're not going to go wrong with those, with really any of those. Okay, and then somebody said, can you put the slide of the first case? I would like to screenshot it. Yes, whoopsies. Okay, there's the first case and my meme that I stole from somebody. Okay, and then it's going to be in the slides that we send out anyway. Oops. All right, and then the next case is, you know what? I think I want to skip this because there is a case. Oh, here, this is what somebody asked about. How can I be sure he's not going to sell his Adderall? What do you all think about this? Oh, and meanwhile, somebody put in the Q&A, what about hyperthyroidism, thyroid disease differential? Did you check TSH? If there's like no physical signs, like there's no change in weight, I don't know. I think it would be low yield. I don't think it would be wrong. For patients, for me personally, if I was seeing somebody for an initial mental health appointment, I was concerned maybe with anxiety or depression. I don't know that there's data to back this up, but I would usually do a CBC and a TSH, before I was starting an SSRI on a young person. I don't think it's unreasonable to check that just to make sure. I just don't know if there's data backing it. Okay, how can I be sure he's not going to sell his Adderall? Okay, well, we're not sure. That's the problem. So we just want to minimize the risk while also balancing a patient's access to care and to these literally life-saving, life-changing medications. So I think an accurate diagnosis